air your dirty linen in front of everyone. So it's definitely not a comfortable presentation, unfortunately. Sorry. How do I shift? Okay. So, I mean, for aorta, the advancement in stent graft design and with our technical skills and imaging quality, we've been treating more and more cases regardless of challenging anatomy. And we've been trying to push the book even further between when we started off with infrarenal and then juxta and suprarenal and then fenestrations and branches and then moving all the way up to the arch at the moment. So obviously with that, the chances of complications get higher. And if we take it all the way back to where it all started with EVAR 1 over 20 years ago, and even with what was just plain simple infrarenal aneurysm repairs, there was a large number of re-intervention rates. So you could obviously argue that the more you're going to do, the more difficult and the more likely you're going to end up with complications. So it's important to understand your anatomy, important to understand and know your devices really well to try and avoid any pitfalls or nightmares. But eventually you will get bitten by sometimes some of these cases, as well as some external factors regardless of anatomy and devices. So, I mean, this is a case where I was called in by a colleague of mine, which was in what started off as a very straightforward infrarenal EVAR. After deploying the main body, they struggled to cannulate the contralateral gate. They had spent a fair bit of time trying to cannulate the gate, and by the time I was called in, they had already kind of extended the deployment of the ipsilateral limb and tried to go up and over to try and cannulate the gate through there. And despite that, they just could not get the wire through. When I went in, the first thing I noticed that contralateral gate actually was squished and that it most likely had deployed inside the ipsilateral limb rather than the contralateral limb. And looking at the patient's imaging, turns out that the distance from the infrarenal aorta till the bifurcation was just over 80 millimeters on a stretch view. Now, my colleague is very, very experienced and assumed that they could get away with it and be able to cannulate the limb. What they hadn't factored in was the fact that as they deployed proximally, it had shifted down a few millimeters. So we did attempt to try and retrieve that by trying to balloon that limb out of the ipsilateral limb and even went from the arm down. To no avail, because it actually had shifted probably about 4 millimeters down into the ipsilateral limb, and we eventually ended up in a situation where we had to put in a plug and a fem-fem crossover. So you win some, you lose some, but at least if you know your anatomy and if things are very tight, then ideally a case like that, you probably would have chosen a different device in the first place rather than keeping it really tight. And then you're kind of, well, okay, you plan really, really well. So a young gentleman, he was 66, and his initial presentation was Leriche syndrome as well as buttock. So he had buttock claudication, left lower limb claudication and impotence, and through those symptoms on assessment and investigation was found to have a 5.6 centimeter AAA as well. So the natural kind of sequence of events would have been to do an aortoiliac for a patient like this, but it was quite adamant that that left leg and the buttock claudication were an issue for him. Again, the fact that he was 66 kind of put us off doing an aortoiliac and a fem-fem. So we decided to at least attempt to recanalize that and do a full biiliac EVAR for him, and giving him the option that if things don't work out, that we would end up doing a FEM for him. So I'm not sure why the videos are not working. Can you probably click the videos for me, if you don't mind? We attempted to go up and over. There's probably a video at the bottom where we managed to cannulate the left iliac. And once we cannulated the left iliac, we went up with a shock wave into that left iliac and managed to open it, and then eventually ended up with a biiliac EVAR with further stenting down into the common and external. So he was covered stented into the common and uncovered in the external. So that all looks really, really beautiful, but obviously the case doesn't finish there, because as we were mentioning earlier on about peripheral embolization, this patient, as we took out our sheaths, we noticed that that left leg was ischemic and ended up with an embolectomy. So with the best preparation in the world, you still will end up with cases where sometimes you eventually end up with complications. Knowing your device is critical. This is a patient of ours where we did an infrarenal EVAR for, and if you can probably see here that you can see both renals following the deployment look really, really well. But if you notice a bit closer, I'm not sure if you can actually see a marker here, that one of the markers was literally just at the level of the renal, and if you know your device quite well, you'll notice that we'll know that that marker is about 3 millimeters below the fabric. So the fact that you can see it right across the ostium of the renal means that you already have fabric shuttering against the ostium of the renal. So eventually what we did was we ended up putting in a stent into that renal artery to make sure that that things are under control. And then there are certain nightmares that are going to happen regardless of what you do, regardless of your anatomy, regardless of your device. So like the cases where you're going to end up having to explant your EVARs. So this is a 75-year-old gentleman, underwent a CABG in 2013, a permanent pacemaker in 2020 on the left side, and then an EVAR with bilateral common femoral artery endarterectomy and a right SFA angioplasty and stenting in 2021. And then the follow-up CT angios of this gentleman showed that things were working absolutely perfectly with no issues. And then, unfortunately, 2023 was a bad year for this man. In January 23, his left clavicular pacemaker got infected and eventually started eroding through the skin and had to be removed, and a new pacemaker inserted on the right side. In July of that year, he got COVID and followed by a PE and was started on a DOAC. And then following him starting on a DOAC, a couple of months later, he had a spontaneous retroperitoneal hematoma. So things were not looking well for him in that year in 2023. A year later, he presented to a satellite hospital with what was diagnosed as a cellulitis. But in hindsight, you would wonder, was it really a cellulitis or was it tracking of the retroperitoneal hematoma at that stage, because it was only a month after the origin of the retroperitoneal hematoma. And at that stage, no vascular consult was asked or sought. And then fast forward to February of this year, again admitted to a satellite hospital with weakness and weight loss, elevated white cells and CRP with negative blood cultures, and his echo showed no evidence of infective endocarditis. The CT at the time, as you can see, didn't show anything out of order, and as such, we were not consulted again. And then moving forward, just 1 month later, that's the image that you see in this patient. Literally a month between those two CTs. So obviously that's a disaster, and we all know what's going on here. That you can see from the patient's PET CT, his EVAR graft is lighting up as like a Christmas tree following his retroperitoneal hematoma, which wasn't responding to antibiotics for about 6 months prior to that. So our challenges here were the fact that if we are going to do an axillobifem, how are we going to do it when he had a previous pacemaker on that site, and then looking at removing the EVAR graft. So we ended up going a little bit closer to the subclavian, trying to avoid the area that was previously infected a few years back. And after doing our subclavian bifem bypass, we ended up extracting his EVAR graft. So it was an infrarenal gore excluder that he had, so ever so slightly easier to extract than one with suprarenal fixation. And then double-breasted the sac, trying to be as meticulous as possible when we were dissecting and closing the sac. Post-op, as you'd expect, AKI that gradually by day 10 was recovering and had shifted from continuous to intermittent hemodialysis, was weaned off his inotropes, but obviously there has to be a spanner in the works. So by day 11, we all know what's happening here. Abdominal pain, tachypnea, and melena, and then on his CT, the patient had pneumatosis coli. So ended up having to go in for a laparotomy and a sigmoid rectal junction necrosis, and the patient underwent a Hartmann's procedure. So no matter what, there will always be disasters, even if you do know your anatomy and your devices. And there will always be cases where you're going to end up having to do a late conversion to open repair, like in cases of graft infection, even though the main issue with late conversion has always been if we are adherent to IFU or not. But this is a case where everything was adherent to IFU, and yet it still happens. I can't see Murad Salem here, but I mean, he would probably tell me that my number of overall mortality of 75% is actually an understatement, but I would take this case as a success because the patient actually survived. Thank you.
Thank you, Mr. Wael. Any question?
Great talk, but I do have a question about this extra anatomical bypass you made, because the guidelines say that number one is actually in situ reconstruction, either with deep femoral vein or with biografts. Did you consider that, or?
We did consider that, to be honest with you. The patient was very unwell at that stage, and we were trying to minimize as much as possible the time the patient was going to be on the table.
Yeah, I understand, but still you have to go to do a laparotomy to take out everything, so it doesn't really matter, I would say.
I know.
Unless you do a deep femoral vein, which takes a few more hours, but yeah. Any other questions from the audience? Yep.
Fantastic case, I feel for you. When you did the extra anatomical, you were worried about the left side. Did you think of taking it from the right side?